Our next speaker is Jim Ogloff, who is a lawyer and a psychologist and another misplaced Canadian who situates himself at Swinburne University in Melbourne. He is the Director of Psychological Services at Victoria Institute of Forensic Mental Health and has worked in clinical and forensic psychology in a variety of settings for 30 years. He's a researcher and a clinician in the area of violence risk assessment and psychopathy, and he's going to be speaking to us today about his research on mental health problems as a precursor to homicide.
All the Canadian accents. I'm an Australian citizen, but I'm the only one who thinks I sound Australian. The Canadians sound funny to me now from hearing Australians all the time. So what I want to do this afternoon first is thank the organizers indeed for inviting me here. And it's always nice. I'm of the generation where the criminologists and psychologists didn't get along very well. My first job was at a university with a famous criminology department where they wouldn't have me. And then once they got to know me, they invited me to be a member, which was a highlight of my life, being accepted by criminologists, and then doing a joint degree with them. So enough of that. So what I'm going to do is talk about something that overlaps a lot with what we heard about today, but focuses very much on a different topic, that being mental illness and serious mental illness in particular. And what I want to do is I want to acknowledge our team, and the primary person is Detective Senior Sergeant Deb Bennett, who obtained a doctorate with us and has been a highlight for me coming to Australia. She did her honors degree in psychology and pursued the doctorate and works with the Victoria Police Force, but is also a psychologist. And Professor Paul Mullen, now retired Professor of Forensic Psychiatry, and Professor Stuart Thomas, now at Wollongong University. And one of the things that I think we know for a fact that I want to spend much time on is the fact that we have incontrovertible evidence now that the prevalence of mental illness is just dramatically higher in the criminal justice system than it is in the general population. Yet it's something that we don't pay much attention to. And I think it's something we don't pay much attention to because it's very difficult. And the study that I'm going to talk about will emphasize the importance of mental illness when one considers homicide. But in case you're not fully indoctrinated, these are the sorts of statistics this comes from some research we've done. This is simply looking at everybody coming into police custody and assessing them. And you can see the green bars, which are very bright. That's people coming into police custody. The yellow are comparisons in the community. And you can see that all the disorders, so psychosis, mood disorders, and anxiety disorders, which in those days included post-traumatic stress disorder, doesn't anymore. The diagnostic stuff's changed, but it did there, and substance use disorder. So that's one thing that's very clear. And what we find is that in particular the psychotic disorders are 15 times greater, dramatically higher, and that'll speak to something relevant to homicide in a few moments. Now, despite that, and you're criminologists and police, those detained are no more likely to have a violent history. So the fact is that when we compare populations, irrespective of mental illness, as a group, there's no differences in the kind of crime they do. That is, they're no more likely to be violent. Now, I don't want you to believe then that mentally ill people aren't violent or won't sometimes be violent. Our research shows otherwise. This is a busy table, but it's based on a very large study we've been conducting, led by Professor Paul Mullen, beginning in 1975. So this is in Victoria. Every person registered with schizophrenia in 5-year blocks from 1995 to 2005. So a sample of about 4,000. And then this looks at simply the percentages and the number of people with schizophrenia who engage in the particular kind of offending as compared to a randomized or randomly obtained community sample matched for age and gender. So you can see that if you take, for example, violent offenses, the second line, people with schizophrenia, 10% of them over the time in their life up to this point, and remember some of them we've been tracking since 1975, so they're now getting on. It's 1 out of every 10 has engaged in some violent offense, a violence conviction, as compared to the general population, about 2.5%. And it's higher across, irrespective of the type of offense. So everything from nonviolent, family violent, and intervention order. The very little, the line at the bottom there, a significant number, and this is a new kind of piece of information because it's relatively new in Australia, having community-based orders in mental health rather than hospitalizing people. Very often people are put on community-based orders where they need to attend at a mental health center, typically to be injected or to take tablets. And we find that in the more recent group, 45% of the people are actually on these orders. And that'll, again, harken back to something I want to talk about with homicide. So that sort of sets the stage for where we're at. So very, very briefly then, mentally ill people are overrepresented in criminal justice systems. They're not more likely than other offenders to commit violence, but they're much more likely than people in the community both to offend and commit violence. And I can add to that, even if we control for substance abuse, those rates are not as elevated, but they're still significant. Now, that raises questions about, well, what is the relationship between mental illness and offending? And then we're going to see how that relates to homicide. So there are three kinds of relationships that we've been able to identify, and these are pretty well accepted. The first is a causal relationship, and in my generation, that's probably what we thought. So we thought that mentally ill people weren't violent, and if they were, it was because of the mental illness. But now, as we see, that's the smallest group, and I'll talk about them briefly. The contributory group are people who offend as a result of the social consequences of dislocation, the downward spiral that occurs when you have schizophrenia or other major mental illness. So you're typically not doing as well in school, you don't get as good a job, you have difficulty in social relationships, you're not stable, and you spiral downward, and you end up often using drugs or alcohol, not having good housing, and so forth. And that's the largest group we see. And then the third group are the people who are probably where mental illness is irrelevant. And these are people, when we trace back their history, their offending history starts very early, and it's likely that they're more prototypical antisocial people. Small group, but a group, they offend when they're unwell, and they offend when they're not unwell. So those are the three groups. So I want to be really clear that when we talk about homicide, we're not saying that the fact that the rates of mental illness are high means that it causes homicide, but it affects homicide in one of these three ways. Okay. Now, there are a range of questions which I won't be able to answer all of them in the time allotted. I do want to leave time for questions. And this group will know most of these issues. Most research on homicide and mental illness has been based on populations of convenience. Usually a group of people who attend, say, at a forensic mental health clinic or a forensic service for assessment. Well, obviously, that's not going to be a very representative group. Little research has considered homicide perpetrators' lifetime history of mental illness. That work is usually a brief assessment or screening. So I've done many of these studies myself where we screen people and we look at their mental illness at the time rather than their history of mental illness. Next is no previous research exists to compare the motives of homicide for mentally ill people compared to not mentally ill. So obviously there's lots of research looking at motives. We've seen some of it today, but they haven't typically teased that out very well. And then the relative effect of mental illness and substance use, and finally gender differences. So those are some of the things that we're touching on. Now what we did is we were able to work again with Deb Bennett and the support of the Homicide Squad in Victoria. We were able to identify all homicides which occurred between 1997 and 2005, and we used the police database and the Homicide Squad database. And one of the great things of working with a police officer is if we had missing information, she would just contact the person who investigated and we'd get the information. So we could almost get everything we needed. And of course, the good thing about studying homicide, as people know, we care about it and lots of data collected. So there's lots of information compared to other sorts of offenses I've dealt with. And then what we did is we took that database, which we constructed, and linked it to the public mental health database. Now in Victoria, we're very fortunate to have one of the longest standing public mental health databases in the world. It dates from 1961. And so we have every contact anybody's had with public mental health over essentially the lifetime of the people that we were studying. So we were able to look at these in some detail. Now, very briefly, during that period, there were a total of 569 homicides. It's the one disappointment moving to Australia from Florida, where I was for a while, is there's just not enough murder. So we had to wait 9 years to get a decent sample size, whereas I lived in Tampa, Florida. We could have had a couple of years and collect that many data or people. Now, in fact, there were 435 offenders who were identified from those 569 homicides. Some had committed more than one, and those were the outcomes. So 197 convicted of murder, 159 convicted of manslaughter, 22 convicted of infanticide, 26 found not guilty by reason of mental impairment, and then 24 murder-suicide, and 64 unsolved. Either there was no one identified or someone was acquitted. So we had a sample size then of about 435 that we looked at for our work. Now, just the highlights. That's really all I have time for. Mostly men, as we know, and within the men, mostly sole perpetrators. About 27% had co-accused, and those data are exactly the same, and I recalculated them again, thinking they can't be the same, but they are. 73, 27 is exactly the same. Decimal point differs slightly. So the percentage of sole perpetrators is the same, co-accused. The difference is that both for men and women, the co-accused tend to be men, much more likely to be men than to be women. And you can see that in the numbers there for the women. So I think as a group, certainly for homicide, slightly higher rates of homicide among women than other kinds of offenses. That difference is slightly greater. But in terms of who's committing the offenses, if they're alone or with someone, that's about the same. Now, of course, the point we were interested in really is mental illness. And so what we found is that 27% had, in fact, received a diagnosis of a major mental illness in the past. And this needs to be emphasized. One woman in our sample had been hospitalized more than 60 times. So we're not talking about someone who had depression and went to the GP, and that's something that's really important. The database records public mental health. So if you went to your GP and you're unwell, that wouldn't get in here. So this is a very conservative database. So these are people who went to public mental health services, including hospitals or community. What was staggering is that 9% had schizophrenia, and that compares with 0.7 in the community. So in the community, it's 7 out of 1,000 people. In this sample, it was 9 out of 100. And when we break that down by gender, they're so high that 1 out of every 5 women had schizophrenia who committed homicide, and a little bit less than 1 out of 10 men. But that's very, very high rates compared to what you'd expect in the community. And homicide offenders were 13 times more likely than controls to have schizophrenia. And the other things I'll come back to in terms of their kind of crime. So I guess the point is it's a very high percentage of people have serious mental illness. And again, the reason I put the relationship between mental illness and offending at first is because it doesn't mean they killed someone because they're mentally ill. The relationship differed. And in fact, remember, 26 of these people, about 6%, were found not guilty because of mental impairment. That is a case where, but for the mental illness, they wouldn't have done the crime. Now, there will be some others that should have been in that category that weren't, but it's a relatively small number. So most of them, again, the mental illness is another significant factor in their life that relates to offending rather than being the causal variable. Now, when we compare this is really good. My there's supposed to be light blue bars there. I suddenly feel like the Dutchman who can't see the screen, except, mine's white, yours is blue. You can see it. So I was looking there. It's exactly the same thing happened, 2 different continents. It's a miracle. Now, if we look at the rates, then you can see for homicide offenders for males, vast differences. And again, as I pointed out, for women, it's actually even higher. And so when we look at women as a subgroup, there are even higher rates of mental illness. And in fact, it's safe to say that very few of our female homicide offenders didn't have some kind of mental health problem or issue. And again, the light blue columns are the people with psychosis as compared to any diagnosis. Okay. Now, this is probably impossible to interpret, but I thought it looked nice. In fact, I thought it looked sort of like a criminologist would do. Does it, Paul? Does it? Will you confirm? Yes, it does. That's good. When I studied, there was no criminology at the university I was at. It was sociology of crime, which I took. And we drew graphs like this. So how I'll interpret that is the bar that's heavier in the sort of top quadrant there, that's the year of the offense. So we call that year 0. So then these are standardized years for the women, and each figure represents a homicide, and that's the female perpetrator. And so you can see this is a very fascinating thing, that this is when they were identified and diagnosed, and this is actually with schizophrenia, the most serious mental illness. So you can see that virtually every woman except one was diagnosed prior to actually the offense, and sometimes 12 years before. And that's what's very sad as a mental health professional. They were, like I said, one of them hospitalized 60 times. So the people in and out of hospital, in and out of community treatment, who go on to commit murder. Only one woman was diagnosed at the time of the murder, and this was done as part of the evaluation that occurs. And then one developed a schizophrenic illness about 4 years after being incarcerated. Now, interestingly, for men, it's a very different pattern. For men, it's about half. So only half the men were diagnosed before, and half of them were diagnosed at the time or later. And that's very important because it speaks to a lot of differences, both in mental health and in offending, between men and women. Now, what's important then is to begin to think about, well, how do the offenses really differ in the group with mental illness compared to others? So I'm just going to talk in the next few minutes as I wind down about the nature of the offense that was committed, and about the motive for murder, and a little bit about the nature of the victim. And I think this is where things become very important and interesting. Now, in terms of the nature of the offense, one of the things we did, and there's controversy around this, is we categorized the offenses along the spectrum that Cornell developed, looking at the extent to which they're instrumental or reactive. And what we did is we coded essentially all of the cases based on what we knew about that happened. And again, the good thing with the homicide cases is in virtually every case, well, in every case, there were sentencing comments where the judge had to sort of ascertain what really happened based on the either stipulated facts agreed to by counsel or by the findings made during the trial. Now, on the one extreme, you have instrumental violence, and that is violence for a clearly identifiable purpose, where there's a reason, and it's really the person had the intent to kill and killed for a particular reason. The other extreme would be reactive, where the violence occurred as a result to a dispute or interpersonal conflict, so sort of push to the crime or things got out of hand. And then, of course, mixed. Now, we were surprised, because this is a controversial area, that we could actually identify them as well as we could. We thought we'd have many more mixed cases than we did. And again, I think it's because of the effort that's put into investigating homicide and many other violent crimes. You may not have the information that we were able to look at. Now, for the non-psychotic group, you can see the proportions. And this is, again, very surprising, at least to people who work in mental health. That is, the predictions most people would make is that people with mental illness would be more likely to be reactive, because there is this sort of, I think, fantasy or misperception that mentally ill people sort of go crazy and act crazy and kill somebody. Now, what we found is they were, as a group, more likely to be instrumental. The difference is, for those who were psychotic, is the instrumentality was irrational. So one case study that we explored was a man who believed that his mother was a witch. And he was a young man without much criminal history who developed a delusional belief that his mother was a witch. And he ended up basically telling people and trying to get help for fear his mother was a witch and was going to kill him and his brother. He eventually got hospitalized in his local hospital. Local area mental health service had him hospitalized, and he was treated and he was discharged. And it was an inner suburb of Melbourne. He went home and he escaped from the house, and he went to the local police station. And he said to the police officers, who were, of course, shocked, my mother's a witch and she's trying to kill me and my brother, and you have to help me. And they didn't, know what to do. This happens a lot in policing with somebody acting bizarre. So they contacted the local mental health service, and they said, yeah, we knew that guy. He was discharged recently. He's basically on medication. And they said, what should we do? Well, call his brother. So they rang the brother. Brother took him home, whereupon within the next day, he killed his mother and then burnt the house down. So his intent was to kill his mother. He had a clear intention. She was a witch. He had to kill his mother, burn her in order to free her spirit. So that's an instrumental crime, clearly motivated and so forth. And he warned people about this, not reactive. So just because the individual is actually delusional does not mean they cannot have thinking about motive. And this, we find, is the big problem in mental health professionals and in juries. In a number of celebrated cases in Victoria and across Australia, there have been people with serious mental illness who have been found guilty, and we don't know why because you can't ask the jurors, but it appears that there are cases where, and sometimes say mothers who kill their children when they're mentally ill. One case in particular we've dealt with in Victoria, where any psychiatrist who assessed this woman believed that she had the mental impairment defense. But at trial, an interstate expert who never examined her basically raised questions like, this is very unusual, and the jury found her guilty. And one of the beliefs is that because these crimes were often premeditated, the perception is if you're mentally ill, you're not going to commit crimes like that, when in fact we found exactly the opposite. They were less likely to be reactive and mixed and more likely to be instrumental. So in our work with police, that's an important thing because police are looking at the crime. The second thing that's important is motives for murder. And of course, this is a well-known area of research. Within motives for murder, there are limited motives for murder, as people know. And the thing that struck us is that the same motives came up for people who had psychosis, but they were actually, as you can see, more likely to have, less likely to have child killing, and much more likely to have that large sort of instrumental revenge component, and the argument is roughly the same proportion. Now finally, the victims. And this is, again, within all homicide, and we saw data that presented this morning, we know that this is very unlikely to be killed by a stranger, and it is the case in someone with psychosis, it's even less likely that they'll kill a stranger. So if you look at these data very carefully, you find that the probability of a person with psychosis killing a stranger is actually very, very remote. The greater concern is acquaintances and, as you can see, relatives and partners. And it's one of the very difficult messages we have in mental health is working with families where an individual may present some risk, and it's usually going to be the family that gets harmed or, in the rare case, murdered. So those are the key findings that I wanted to share. There's implications, obviously, for the mental health service, and like I said, in our case, particularly for women, but also for most of the men, they were already in these services, and it was just a matter of potentially not managing them, or in the case study, not taking seriously this man's fear and threats that he was going to need to kill his mother. Serious implications for criminal justice. Police need to understand this more, and one of the very interesting points is and this is what Deb did, when she looked at the homicide investigations initially, she looked at how many had identified people with mental illness, and it was grossly under-identified. It wasn't data that police were routinely collecting, and it was potentially helpful. And finally, obviously, lots of public policy issues around the intersection of mental health and criminal justice. So we got lots more data, but these are the first couple of studies that I wanted to share.